My name is Katelynn Bachman, and thank you for the opportunity to present at SAGES Virtual this year. Low volume robotic esophagectomy is associated with inferior survival. These are our disclosures. Robotic minimally invasive esophagectomies, or RIMI, have been associated with superior outcomes when compared to open approach, such as lower complication rates, less postoperative pain, and shorter postoperative length of stay. The advantages of the robotic approach are supported in high volume institutions. However, benefit of robotic approach in lower volume centers is unclear, and long-term survival has not been studied. The objective of this study was to use the National Cancer Database, or NCDB, to determine whether patient and oncologic outcomes after robotic esophagectomy are comparable at both high and low volume institutions. We hypothesized low volume robotic esophagectomy centers would have inferior outcomes. We performed an analysis of the United States NCDB from 2010 to 2016. We included patients that were adults that received robotic esophagectomy and included conversions to open. We excluded those patients that were missing important treatment data, such as operative approach and clinical metastatic disease. The total number of robotic esophagectomies performed by individual institution was divided into quartiles. For analytic purposes, institutions were classified as those who performed 9 or fewer, which were the lowest quartile, or greater than 9 robotic esophagectomies, the top 3 quartiles. We then studied short-term outcomes such as margin status, number of lymph nodes evaluated, length of stay, unplanned readmission rate, and 90-day mortality. And the primary outcome was overall survival. 1,565 robotic esophagectomies were performed by 212 individual centers. 173 hospitals performed less than 9 robotic esophagectomies, and 39 hospitals performed greater than 9 robotic esophagectomies. Interestingly, 60% of hospitals performing robotic esophagectomies had performed less than 4 over the study period, and the yearly total of robotic esophagectomy has increased significantly since 2010. Age, sex, insurance status, and Charleston Comorbidity Index were similar between the two groups. High volume centers were more likely to be academic institutions compared to centers which performed less than 9 robotic esophagectomies, and the majority of the patients in both groups had esophageal adenocarcinoma. Although patients at high volume centers had a higher percentage of clinical T stage 3 or 4 disease, there was no significant difference in clinical end stage disease. More patients treated at centers which performed more than 9 robotic esophagectomies received neoadjuvant radiation, but there was no difference in neoadjuvant chemotherapy. Short-term outcomes of the robotic esophagectomies are summarized in the table above. High volume centers had a greater number of lymph nodes evaluated, and there were similar rates of positive margins and unplanned readmission rates between the two groups. Patients treated at high volume centers had a shorter median length of stay and reduced 90-day mortality rate. Multivariable logistic regression examining the effect of clinical variables on 90-day mortality demonstrated low-volume robotic esophagectomy centers had an increased risk of suffering and 90-day mortality compared to patients at higher volume institutions. Importantly, the total number of esophagectomies, including open, thoracoscopic, robotic, were not associated with 90-day mortality. There was no association between the number of robotic esophagectomies a hospital had performed and the likelihood of obtaining a positive surgical margin, nor the likelihood of an unplanned readmission. Patients treated at low-volume centers were associated with a reduced lymph node harvest. However, greater experience performing any type of esophagectomy was associated with an increased number of lymph nodes harvested. Low-volume robotic esophagectomy centers also had an associated increased postoperative length of stay. As shown above in the Kaplan-Meier curves, robotic esophagectomy in low-volume centers had significantly inferior survival when compared to high-volume centers at 37.3 months median overall survival compared to 51.5 months. Multivariable Cox regression analysis examining the effect of clinical variables on overall survival also demonstrated an association with poor survival for patients receiving robotic esophagectomy at low volume centers. Despite studies supporting robotic, minimally invasive esophagectomy, our analysis of a large national cancer database demonstrates there is an association between low volume centers and reduced numbers of lymph nodes evaluated, increased 90-day mortality, and reduced overall survival. These data argue for a regionalization of robotic esophagectomies to higher volume hospitals or a greater emphasis on training and improving access to robotic esophagectomies at lower volume centers to achieve optimal patient outcomes. Thank you for the opportunity to present at Virtual Stages this year.